time is the overflow of information. And I think this statement is quite probably more true for genetic information. Because of the advancements of major technologies, now we have sequences from hundreds of thousands of patients, but we have very few people to interpret them. We have very few bioinformatics pipelines to make meaningful interpretation of those. And especially the oncologists who are limited in number, but who have to attend enormous number of cancer patients, they are now challenged to make the use of the genetic information. And this is the place where the genetic counselors can contribute. And how we can do, how we can make the best use of genetic counseling in Bangladesh, that is the topic of my presentations. I am going to discuss about the scope of cancer genetic counseling in Bangladesh. Before going to my presentation, I want to pay tribute to my mentors, Sir Walter Bodmer from University of Oxford, under whom I did my DPhil in oncology in 2017. And then in 2025, I did a fellowship on genetic counseling with Dr. Joan New from National Cancer Center, Singapore. I'm an associate professor in the University of Dhaka, founder of Cancer Care and Genetic Research Trust Bangladesh, and I have founded the first cancer genetic service company in Bangladesh called GenPath. So what is genetic counseling? I'm thankful to Trisha, who has introduced the field, but I want to start with the basic definition, which is it's a systematic, evidence-based process that utilizes available and clinical information to address an individual's health concerns. It aims to support informed decision-making, risk assessment, and personalized care planning, ultimately promoting the well-being of patients and their families. So it's very important that genetic counseling is not concerned only about the patient, but it also extends the care and the support for the family. So the core components of genetic counseling, it involves, the very first thing is when we do genetic counseling, we have to build the rapport with the patient or the client who is coming to the clinic. And then we have to take extensive family history and pedigree. We have to do risk assessment using the NCCN or other prescribed guidelines. We have to do patient education. That means that we need to make the patient aware about what's happening, what's the significance of the findings, of the genetic findings that we get. And we have to coordinate the test. That means sample collections, lab choice, cost discussion is very important, because when you go for large panel, it involves cost. And finally is the post-test plan, which is the most important thing. You have to interpret the results, advise surveillance or preventive measures. So before going to the scope in Bangladesh, I want to briefly highlight the purpose of genetic counseling in clinical and family health. So I'm not going to read all the text here. Mostly, the first thing is the purpose of genetic counseling is to interpret the genetic findings. So that involves translating complex genetic trait results into understandable language. So that's the first need as a genetic counselor, that we have to convey what the outcome of a genetic test means for the patients. The second important thing is patient-centered risk assessment. So when we find a genetic result, whatever mutation it is, whatever variant it is, pathogenic, non-pathogenic, or a variant of unknown significance, we have to evaluate personal and family history to estimate the likelihood of genetic disorder. The third thing is we have to find the impact on family planning and relatives. There are certain hereditary genetic markers that will indicate whether the risk is going to flow to the next generation. So for that, we have to offer reproductive guidance for individuals or couples at risk. And fourth is the psychosocial support and decision making, which is extremely important, because whenever someone will get a genetic result, whenever someone will find that there is a marker which is hereditary, then the person probably has to navigate through a strong emotional response such as anxiety, guilt, and uncertainty. And in the genetic clinic, we have found that a lot of people will have lots of family tensions when a genetic result will come out. And when we provide the support, we have to be respectful about cultural, religious, and personal values in health planning. So with this brief background, I now come to the major questions. Are we prepared to practice genetic counseling in Bangladesh? We have learned from Trisha that they're doing this in India, but where do we stand in Bangladesh? Before going to that question, I will start with the very basic component of genetic counseling, which is the technology that involves getting the genetic results. So Trisha has mentioned that it can be PCR-based, it can be next-generation sequencing-based. Where do we belong into this picture in Bangladesh? I want to start with some of the findings from my research. So we do research in Dhaka University in Genetic Engineering Department. These are the results of targeted sequencing of EGFR, and we tried to identify whether some of the common mutations that are important for drug selections for non-small cell lung cancer, whether those are present in EGFR in particular patients. So we sequenced some of the samples from the patients, and we found that in our case, obviously from targeted sequencing, we could identify a deletion mutation that you can see in the red marked line. So EGFR we can identify, it's a targeted sequencing. And then for KRAS and BRAF, which is also very important for colorectal and also lung cancer, that can also be, these are point mutations, so these are also possible to detect using targeted sequencing. So when we do targeted sequencing, we will first do the PCR that you can see from the left side panels. So we do PCR gel run, we take the band, and we go for the Sanger sequencing, which is also known as targeted sequencing. And we can also do for PIK3CA, which is essential for the selection of alpha-LCBL fulvestrant combination therapy. And that is also possible to detect in our labs. But in Bangladesh, we are not only limited to targeted sequencing anymore. It's not that Sanger sequencing is only possible, but next generation sequencing are also available in Bangladesh, and it's quite accessible. We have one of the chair of this session, Dr. Mustafiz, who is leading the Genome Center in ICT DRB. They have the next generation sequencing facilities. And as of now, probably around 52 or 53 next generation sequencing machines are available in Bangladesh. And those can be accessed and harnessed for the large panels that we need to do for hereditary cancer syndrome detection. So Trisha has mentioned about BRCA1, BRCA2, but there are certain other genes which are also involved in different other cancers. So this is kind of a summary of some of the leading hereditary syndromes. The first we can say hereditary breast and ovarian syndrome, HBOC. Then hereditary ovarian cancer syndrome, Lynch syndrome. I will discuss about Lynch syndrome a bit later. Cowden syndrome, Liebowitz syndrome, and Peutz-Jeghers syndrome. So these are the hereditary syndromes that are very well studied, and generally among all cancers that we detect, 10 to 15% will be probably will occur because of the mutations of some of the genes. So that means for hereditary cancer, sometimes we don't have to go for very large panels. If we are a very good genetic counselor, if we can assess all the information, then probably we'll be able to narrow down the choice of gene panel, and that will reduce the cost for the patient. So here I'm taking an example of Lynch syndrome. For Lynch syndrome, these are the genes which are involved. You can see there are 6 genes which are mostly involved, but mostly colorectal and endometrial cancers they occur because of MLH1 and MSH2 mutations. But these mutations are spread all over the genes. That means like EGFR or KRAS BRAF, I cannot go for targeted sequencing. I have to go for next generation sequencing for the gene. So this is the knowledge that we have to choose the technology when I go for targeted sequencing and when I go for next generation sequencing. So let's consider this classic Lynch cage. This is a This is a case where you can see on the left side, lots of family members are affected with different type of cancers. Some of them have colorectal cancer, some of them endometrial cancer, breast cancer. So just the pattern of the cancers in a family can indicate what type of hereditary syndrome they may suffer from and what are the genes that might be involved in. So for this particular case, a good genetic counselor will not go for like 100 of genes, because just the panel indicates that probably it's a very strong case of Lynch syndrome. That means we can probably be limited even just within these 6 genes. So when we did sequence for these patients, we actually found that the person has a pathogenic mutation in MLH1 gene. So that means that it is possible to detect, and it is possible to detect within the technology which is available in Bangladesh at this moment right now. But if we want to implement these things in Bangladesh, then we need some local adaptations. That means we have to use Bangla language for family history forms, because so that people can communicate very easily with the genetic counselors. We have to include names and relationships in culturally familiar format. That is very important. We have to note common extended family structures in rural and joint households, because in Bangladesh, we have actually extended family structures. We have to address sensitivity around reporting consanguinity or adoption. And we have to train staff to understand the ACMG symbols and criteria. So according to ACMG symbols, a mutation can be either pathogenic, likely pathogenic, BUS that Trisha has already mentioned, or can be likely benign or benign. So benign or likely benign means there is no significant risk, but if it's pathogenic, that is disease causing. So we have to understand what's the significance of these findings. But the main question now is, are we prepared to use the technologies? Are we aware about the technologies? Do we have the knowledge to use those? So we did a small study in Bangladesh. These are the findings from 90 responders. We asked them about what are the main challenges you face in applying molecular tools in practice. And molecular tools mean the test that the clinicians will provide to the patients. And they said lack of training, lack of knowledge, cost of training is obviously an important issue, limited lab infrastructure, patients' understanding about the whole concept. So you can see that the main challenges are coming from awareness and lack of knowledge among the practitioners, and also the awareness among the patients. So we have to overcome this. And to overcome these challenges, I have actually developed a model. I call it pit filling model. That means I think in this room, there is not a single person who doesn't know that genes are involved with cancer. And obviously you already know, some of you probably are practicing these things in your clinic, but probably you need a little push to make the maximum use of the technology and of the knowledge. So for that, people will have different level of knowledge and different level of gaps. So I'm suggesting that if we pick the people according to their motivation, according to their knowledge, and according to their skill, then probably we'll be able to raise some of the people earlier to the level of experts, so that they will be able to provide the necessary supports in Bangladesh. So that is the model that I'm proposing here. But at personal level, I'm not stuck there. As I have mentioned, that I have completed a fellowship in National Cancer Center in Singapore. So with that knowledge, I have actually started an initiative here. It's called GenePath, from where I'm pioneering the cancer genetic counseling. But before counseling the patients, I think the educational part is most important. So I'm organizing workshops for clinicians and also any students, clinical students or university students. I have also compiled a small quick book on cancer genetic counseling. It's written in Bengali, so it's also free to access. So all these resources are available through the website of GenePath. So through GenePath, I have introduced the genetic counseling service in Bangladesh based on my learning and experience from Singapore. The model in GenePath is I'm closely working with the doctors. So any doctor who wants to get the support for genetic counseling can send the patients to me, and I will be able to explain all the genetic significance. So the first visit is actually free, because as I said, the awareness about genetic counseling is quite low in Bangladesh. So first visit is free, and the second visit, well, the patients can then bring all the reports and all the information, and then the second visit they have to pay something, and then doctor will follow. Everything is doctor centric, the clinical oncologist centric. I just provide the support to understand the genetic significance and everything. So this service is already available, and I'm working with some of the leading clinicians here and have organized several workshops, as I mentioned. But I'm really looking forward to further collaborations with all the esteemed colleagues here, all the leading clinicians, oncologists, and other researchers who are really working hard to make the cancer patients better and to transform the field for the betterment of our patients. Thank you so much, and I acknowledge all my partners and all the funding bodies from Bangladesh and abroad. Thank you so much.
Thank you, Dr. Mustafa.
Good evening, everyone. My name is Mahmudul Hasan. I was born in Bangladesh, but last 24 years I've been living in Finland. So my background as a software engineer, I started to build this company, Ambition AI. So I've been working with AI in radiotherapy for last 8 years. So cancer is very personal to me. So that's why I have dedicated last 12 years of my time with this to solve this problem. So over the last 12 years, I've been involved in radiotherapy, and one thing struck me when I started working in this industry. The first thing it struck, like when the patient actually start the treatment, it takes so many weeks. Even in the developed country like in Finland, the average is roughly 2 weeks, sometimes 3 weeks. And even in UK, that even costs like 4 weeks to 8 weeks. So as an engineer, it's always struck me why this process can take so long time. So as an engineer, I think like in a first principle basis. So I wanted to break down the problem into multiple domains. So the domain of radiotherapy, why it takes so long time? Because it has a lot of sequential tasks to do. So these are manual tasks. It takes a lot of collaboration, and it's multidisciplinary, and organizing all that, and also in the same time, since you're treating patient with radiation, you also have to understand where the radiation goes, because ultimately it's a poison. So how do we solve that problem? Our vision has been to implement AI to make the whole treatment process much faster. There are 4 key things. The AI will automate all the tasks. Then we can do the treatment in hours, not in days or even weeks. And it would be better for the patient care with a high safety and the standards in mind. And how we do that at Envision, I just wanted to give you a glimpse. So in Envision, we developed different kinds of specialized AI models to solve all those chunk of problems. So we have this Control Plus product that's a AI-based segmentation system. So basically you give it a CT or an MRI scan or a cone beam CT. It can segment and generate the 3D volume in minutes. We also developed a dose prediction engine where you just provide the CT, the segmentation, and a prescription, and it can produce a 3D dose in minutes. We also utilize the power of synthetic imaging. As you know, in radiotherapy, the CT is needed for the dose calculation. So synthetic imaging plays a very important part of that. And to match the daily imaging to the patient, we also developed an AI-based product called Adapt Plus, which can automatically register these products together. But these AI models, they do not know how to talk with the human, right? So there is a need for a human-AI interaction, and we developed this platform called Workspace Plus, where the human and AI integrates and operates as a single entity to deliver the result. The other important part we started to realize since 2020 that the AI is, it does not know is it right or wrong. It can make systematic error, and we actually have a peer-reviewed publication showing that the human complacency or dependence of AI is true. So for that, we actually developed this platform where we encourage our users to use the best training tool so that understand how the AI is behaving, and they have the domain knowledge better than the AI. I'm pleased to say that our platform is operational in 24 countries, and we process roughly around 200,000 patients through our platform. So I'll just briefly tell you a little bit about these products. just to see how it really works. So the Control Plus is a guideline-based segmentation system. And this, so you may have heard our workshop a few days ago. And the workshop is all about teaching and training about guidelines. When we developed our first AI model, one thing that we immediately realized that how you draw the organs, there is different interpretation for different people. And I distinctly remember there was a particular oncologist whose data we have taken and trained the model, and he has a very particular way of doing the lymph node, and that's like nobody else in the world does that sort of lymph node. And that sort of like struck us like, if these 3D volumes are like a matter of interpretation, and then it interprets in a different way, how can we make it uniform or consensus driven? Luckily, we came to know that there are different guidelines available for this. So right now, our platform supports around 25 different guidelines that is implemented in our platform. Since the implementation of this product, it's been saved like tons of hours and weeks and months for the customer. And our customers, so every time say like that we really save their like evenings, particularly our customers in UK, the consultants typically take their work at home. Nowadays they have Envision, so they don't have to take, so they can spend time with their family. The second product is called a dose prediction engine. So it is basically helping to guide the plan optimization. So the problem of planning, as you know, it's a very difficult problem, because the optimization is basically, when do you know to stop? Because the mathematical model can like continue to optimize. There are trade-offs, and who knows the trade-offs? So it's a very, very complex problem, and there is no standardization process. But having said that, actually, we do have references of good plans or good practices that can be generated as a digital knowledge and teach the AI to predict. So that's what our attempt with this product. How this product works is basically we kind of qualified a vast amount of training data with a particular quality. And then we kind of deployed this model, and the prediction is actually, I have to say, in our clinical validation, it shows that it's 90% of the time the AI was predicting better than your retrospective plan. So that's what gave us the hope, and so we actually brought this product to the market. And initially, it's actually saving a lot of time, and now we started to understand it's also standardizing the planning process. For example, many clinics, when they do actually the VMAT optimization, they would put different kinds of support structures and things like that, which must have been a very old practice. Like if you're using like Eclipse version 11 or something, and Eclipse has updated already 10 times, but your practices has not been changed because the optimizer has been changed. So you're having this kind of I would say, bad habits of planning, and that can be now eliminated by having a standardized AI model that can predict for that particular case. So we're seeing a tremendous uptake and interest in this product. And in the same time, it is really speeding up the whole planning process. So now synthetic imaging, as you know, in radiotherapy, you need to have the electron density map to do the dose calculation. And more and more, the demand for MR is growing really, really rapidly. We're seeing rapid growth of this MR-based simulation in the US and many developed countries. So we developed this product. But particularly what I'm more interested to tell you about is a cone beam CT enhancement. As you know, on the daily imaging, when you have the cone beam CT, the contrast is so really bad, you really don't know. Like sometime when I was in the treatment room and seeing that they're trying to match the patient, it's kind of like, do they really know where the patient is? Probably not. But now AI can help. At least it has the knowledge to translate this image or enhance this image. So there will be more confidence in dose calculation, also image matching, giving the patient better care. The last part is adaptive planning support with our Adapt Plus. So it's an AI-based, deformable AI-based registration. So it will help you to automatically do the offline adaptation or dose accumulation and personalize the plan for your patient. And I say online adaptation, it's of course subject to the interfaces with the Linux vendors. So, well, I mean, the Linux companies, of course, this is a closely guarded, it's closely guarded, so it doesn't have an open option. But some Linux vendors started to show that there would be a this kind of interfaces so that we should be able to develop this kind of online adaptive therapy with our platform. So the story comes together with this, we call it a clinical decision support system. So you need treatment planning system for your planning, and you need a treatment decision support system to analyze what the patient would need or expect. In my humble opinion, the radiation oncology is it's two components: a radiation biology and a radiation physics. So in the radiation physics, of course, the planning system, you have your QA and all sorts of way to make sure there's the right beam, the right geometry, it's going to the right target. And in the biology side, well, the clinician needs to assess the toxicity, what are the trade-offs, and how can we, do we have alternative options? So a lot of our customers are asking, like, can we have a dose prediction for a proton or a photon, so I can compare without actually doing the whole planning, or is this patient would benefit from a proton plat or a photon? So that's why this is more sort of the clinical decision support system, and this will be a total game changer because this interface is also web-based, meaning we are bringing all the new web technologies into this platform. If you want to do remote peer review, all you need is a web link, and you can collaborate with the patient no matter where you are. Your oncologist could be in Harvard, and your patient could be in Nigeria. Our platform actually supports that kind of collaboration. In the same time, it's an AI assistant as well. And in the same time, it also collects all the telemetry data. So that means it can also learn and improve. And it can do it in a much faster rate than our current traditional software upgrade cycles. So this is the vision I've been working for last 10 years. So we just got the regulatory clearance for this product in Europe. So our customers will start to get this rollout in next few years. So I could be super, super excited. But you know, this is a clinical system. So without any evidence, I'm just telling you a story. So from that perspective, as I said, we have been in the market for the last 8 years. So we have customers all over the world, and they have been doing we have over 40 publications, and in these publications we actually shows the quality, consistency, and the rigor that we put into this product. It's really, really important. So throughout this process, one thing we learn the hard way, it's everything is about the quality of the data. I cannot stress this enough. The AI is nothing but a brain, and it has neurons, and it has to learn. What it learns is controls its behavior. So we cannot control how the AI is learning, but we can definitely control what the AI is going to learn and what the AI is going to do. So that's the control that we have, and I think that's how we can best understand and implement this. And the data curation is absolutely key. So this is the humble learning for us for the last few years. So bring the whole things together. How can you do a SIM and treat in the same day? So you have your CT SIM coming in. We have an AI pick that up, doing all the segmentation, including GTV, CTV, OARs. And once that is done, we have a remote review process. The oncologist would be notified, and it can also collaborate remotely. Once that is complete, then the oncologist can predict the 3D dose by himself or herself. It doesn't need a physicist or a planner to do that because the AI already can do that. Then it goes to the physics team for the plan QA, review, and delivery. So I envision a day where your standard, maybe the prostate cases or a breast cases, patient would come 8 a.m. for their CT simulation. By 11 a.m., they would receive the first radiation and go about their day. We're not stopping only on that. We are heavily investing in multimodal AI, federated learning, because one thing we also started to understand that the clinical know-how in terms of the gross tumor volume, the tumor characteristics, it's so much patient-specific and it's so much knowledge that driven by the oncologist that cannot be easily aggregated. That only can be aggregated in a federated learning manner to speed up the whole process. One of the issue of this medical grade AI is basically access to data. This is actually far difficult than anybody can imagine. So one easy way to address that is federated learning. So that's something we are working on. We're also working on like real-time QA and beam prediction, meaning also it generates the whole plan. And this is the thing I'm more excited about, is an AI assistant that's sort of a large language model where the AI will interpret what in the imaging. For example, it can also would be integrated the NCCN guidelines. So when you draw the tumor, it can give you the guidance, what's the staging, what the prescription you want to follow, and what's the NCCN guidelines say. It can also mix and match. So this is, we just started our research project, and science are exciting and really, really excited about this. And we are global from day one. That's why we build the platform cloud in mind. It's almost like if you're using Microsoft Word and Google Doc, the user experience is totally different. In Google Doc, you can do remote collaboration, all sorts of cool things, which you cannot do in Microsoft. So we are actually becoming the Google for radiotherapy. So last way, I just wanted to show you a quick video. What is the AI actually can do today? So here, we have a cone beam CT. As you can see, the contrast is not that good. So we will run a synthetic imaging, and it will send that to our cloud, talk to the AI, and it will generate a synthetic CT out of this cone beam CT, where you see the contrast is not that great. So we are using some kind of a transformer language to do this. So it's literally in 30 seconds does that. Then we just run the segmentation, because I now have a reference CT. So this is just to give you, this is not a clinical example, just to give you an example like what the AI is capable. Okay, the segmentation should run in a few seconds. Well, it did badly on the body because it didn't have the full body of view. So now I will just run say that I just wanted to see what the dose would look like for this prostate. I didn't put any margin on that, just to give you an idea. I want to just explore what sort of the radiation dose this patient should get. I'll probably say, okay, I should put 60 gray. Let's see what happens. So in few seconds, you'll see the 3D dose distribution. There. And I can review the dose objectives. So you can make an informed decision what could be the starting point for this patient. And this is already helping you to decide what should be the patient's should get. And this is so powerful and exciting, I cannot explain this to you. So, faster planning saves time, smarter planning will save lives. So with that, I'm Mahmudul Hasan. Thank you for your attention.